Welcome to this episode of the Movement Prescription podcast, supported by the British Society of Lifestyle Medicine. Join Callum and I in conversation with Rob Bird, who is a clinical physical activity specialist and exercise consultant. Learn what this actually means and how he got here, from his frustrations with the fitness industry in the 1990s through various qualifications and certifications. Learn from his pearls of wisdoms about how exercise is the cornerstone of health. And remember that the physician message is really one of the most important tools that we have. I hope you enjoy it. Rob, it's an absolute pleasure to have you here today. And we're really looking forward to learning from all your experience and wisdom in all things physical activity. And so we were just chatting before we came on the podcast. And I understand you're a clinical exercise consultant. Could you tell us, what does that mean?
Interesting question. Yeah, hi guys. Thanks for having me on. What's the clinical exercise consultant? Well, I guess we are a group of people who have a clinical understanding of physiology and how exercise integrates with that. So from that perspective, we're very different in many ways to normal exercise instructors because we have a clinical background. So that gives us an insight into clinical conditions, pharmacology, and how exercise kind of integrates with that.
So could you tell us then just a little bit about your journey and how you came to that point, Rob? Would love to hear a bit more about how you got there.
Well, I started in the exercise industry in the mid-90s and realised very quickly that gyms were full of people who were fit already and didn't really need to be in that environment. The people who were really going to get a benefit from physical activity, bearing in mind that ACSM were always quoted on all of the courses I did, the people who were going to get the benefit weren't actually coming through the door. You know, we know that exercise has a massive impact on many clinical conditions, yet most of the people in the gym didn't fall into that remit. They were people who were fit, people who were training for events, people who were training to go on holiday, and we were kind of missing the point, really. So I went off and did some stuff in the US with the American College of Sports Medicine and learned a little bit more about clinical exercise. I came back to the UK and did a master's degree in 2007 in exercise and behavioural medicine. And then in 2011 did some stuff around preventive cardiology with Professor David Wood at Imperial College and kind of evolved my business from there, really. We know that, as I say, exercise is incredibly beneficial for people with clinical conditions, and I've developed a business around that.
Rob, it's really interesting you started in the 90s. There's a lot of kind of lycra and spandex, but also the other thing which is really interesting about the 90s is we kind of we were quite reductionist in the way that we viewed the body. You know, the things in the gym were often cable machines, and you worked out you worked on a single kind of muscle group at a time, and it must be really interesting to see how that the fitness industry has evolved. I can see how it would be very easy to be disillusioned by it, and no doubt you're ahead of your time. And now we have things like CrossFit, which are great because they integrate full body movement, but at the same time, it's quite exclusive and still has those challenges that you talked about, which is that actually it only appeals to a certain group of people who are probably going to be active anyway.
Yeah, I think you're right. I mean, the fitness industry evolves every year, and with January coming around, I suspect we'll have another new evolution, which won't really be one at all. The reality is that the client base I deal with, yes, of course, we talk about functional movement now, and we didn't back in the 90s perhaps. But I often wonder what functional movement actually is. Function is different for everybody, isn't it? And the client base I have, function means different things to different people. You can have a stroke survivor, function is very different to someone who wants to run a 10K. So I think the word functional is good. I think sometimes it's misused and it kind of crosses over, perhaps in not a very good way, because the functional fitness sections in modern gyms now are battle ropes and all these kind of things that you'll see. But I'm not necessarily sure that's relevant to my population group. So, yeah, you're right. The 90s was very different. Now we're very different, but I think we all ended up in the same place.
Rob, I'm interested. What is your client group? What would you say your average patient is like, sort of demographically?
Demographically, I would say most of my patients are 45 plus. I would say the vast majority of my patients are 60 plus. and they're coming to me. They're self-referred, actually. We don't have a referral pathway, at least by the NHS in my local area. They come to me on the back of a diagnosis or an abnormal blood test or an event. So you may have someone who comes here who's been told they've got metabolic syndrome, for example, or they might not want to go on insulin. They might be diabetic, don't want to go on insulin. There are people here who have had strokes, cardiac rehabilitation, those kind of things, cancer survivors. So it's quite a unique group of people, really. And these are the people that probably wouldn't go into a mainstream facility anyway, whether that's through fear or they perhaps wouldn't be served for.
And I guess what's really interesting is that you've got a self-selecting group there. Yes, they are diverse, but they are already quite a long way around that cycle of change. And you mentioned there that there isn't an NHS referral pathway. And obviously, someone like me, a GP working on the front line in a very deprived demographic, the hardest part for me is getting patients across the threshold. But I suspect you've got a lot of lessons and probably a lot of advice for how do we get people to a facility like yours?
Well, I guess the question is, and I'm guessing look at the areas you guys are working with is the same, is we don't yet have an established referral pathway. There is no template for referral. And so for you guys, I guess the question is, how do you actually identify which exercise professional to refer to? And that's difficult. There's work in the background by an organisation called ZIMSPA, who are the Chartered Institute, and they are working with level 2 and level 3 instructors and level 4 instructors. But that's going to be a piece of work that's going to take some time. So there is also Clinical Exercise UK now, which is an organisation I'm very interested in. And they are certifying clinical exercise specialists, people who have degrees in the field. So from a medical perspective, I suspect they would be the people you would be better referring to if we could at some point get a referral pathway, which, as we know, is not necessarily there yet. Most of my referrals are self-referred off the private sector.
A couple of questions just on the back of that. The first is, self-referral still requires people to hear about it. And so how are they hearing about it? How are they saying they're coming to you? And the second is slightly independent of that, but you mentioned ZIMSPA and the different pathways for certifying as an exercise specialist. I think it's a really murky water and quite hard to unpick. Say you're either listening to this podcast because you want to engage in that, or you want to do some more exercise. How do you go and find someone that is appropriately trained for you that might have chronic conditions? So, sorry, two parts or two different questions.
Well, first of all, the referral pathway, people find me by word of mouth. I mean, my business is established. I've been doing this for nearly 30 years. So a lot of clients that have worked with me are passing on the information about their successes, and that's kind of how they find me. It's unfortunate that there are not many more people engaging with me. I have a busy practice for sure, but there are probably many people out there who are missing out because there is no established pathway. So in answer to your question, most of my stuff is word of mouth. And as I say, that's something that needs to be addressed. And I'm hoping ZIMSPA or someone similar will do that at some point. I know some GPs have GP referral pathways into local fitness centres, but that links into your second question, really. Some of the people in fitness centres are going on basic courses. There are some level 4 courses, and just so you know, level 4 courses classed as something that has a medical content. And depending on how you risk stratify your patient, then some of those instructors may be appropriate. So a GP referral pathway into a mainstream gym may be a way for you to think about it. And ZIMSPA do charter level 3 and level 4 instructors, I believe.
Rob, can you just, for me, I have no idea, but also hopefully for listeners, what is a level, what does it take to be a level 3, a level 2, a level 3, a level 4, if that makes sense?
Level 2 are very short courses and a basic, for sure. Level 3 are a step above that, and they'll be multiple weekends in duration or a couple of weeks perhaps. And they'll cover physiology and basic exercise prescription in a bit more depth. By the time you get to level 4, they're talking about specific clinical conditions, cardiac rehabilitation, cancer, those kind of things. And some of the content of those courses, I've done a lot of those courses over the years, are really good. And they open the door for more information for the instructor. But they have quite a strict risk stratification criteria, which means a lot of the complicated cases probably wouldn't be referred to those people either. And that's where the clinical exercise stuff comes in. We're taking on clients that no one else would take because we have an understanding of complex pharmacology and comorbidities and those kind of things.
That brings me really nicely onto a question that I've often had, because I'm not clinically trained to, when it says to patients, ask your GP before embarking on a new physical activity regime. I haven't had the training for that. We are quick learners. So what do we need to know?
Oh, that's an interesting question. I mean, depending on, we know that exercise is good for us, right? We know that. And we know that everyone should be probably more active, or at least most people should. I guess it's difficult for you guys because you don't have very long in your consultations to actually unpick this stuff. For me, it's really much easier because I have time with clients to get to know them, what makes them tick. What you need to know, specific conditions have specific criteria around exercise prescription and what you do. And there is some good resources that I can definitely direct you towards, one that I would recommend every GP to have in their surgery. And as much as we've got multiple guidelines online, there is the ACSM, American College of Sports Medicine, have kind of been pioneers in this stuff. And they have a small book called Guidelines for Exercise Testing and Prescription, now in its 11th edition. And if we could get GPs to have that in their practice, you can turn a page and have a summary of clinical conditions and considerations. And I think that would be a really useful resource for all of you, actually.
I've not heard of that one. I'm going to put that on my Christmas list. Callum?
I've read it, Rob. I agree. I really enjoyed it. I actually did it. I didn't know about it, but I did the diploma of exercise medicine, which is the Faculty of Sport and Exercise Medicine. Released it. The first run was last year, or 2024, and that was the core reading. And it's quite nice. It's only about 120 pages or so long. It's very concise. You can pick it up, put it down. But yeah. Thanks for recommending it.
And it's like a resource manual. Okay, it's clear, it's concise, and it summarises. So for you guys, you could turn a page, you could look at a specific condition, and it will give you a list of contraindications, things to consider. So, and a conversation from a physician, we've got lots of evidence for this, really carries a lot of weight. It's all very well for somebody like me telling people maybe they should do X, Y, and Z, but if it comes from their doctor, it seems to carry a lot more weight, which I completely get, quite frankly. So we want to make sure you're giving them the right information before they leave your surgery.
And that's really good advice there. And I'm looking forward to having a resource on my table. Just for people who like online resources, is there an online version?
You can look at the ACSM website, and there's quite a lot of exercises, medicine resources on there. And you don't have to be a member of the ACSM to access some of that stuff. And the reason I mention the ACSM is because they've been around forever. They've written all the guidelines for all of the training companies. If you go on a level 3 course, they will quote ACSM guidance. So it's always been there.
So give me a little crash course then, because I know from a lot of colleagues that they'll be really worried, particularly about patients with breathlessness, patients with asthma, with COPD, for example, and especially ones with exercise-induced symptoms. So, what would your advice be to, what would you wish that GPs knew about that? How can you give us confidence?
Well, there's a whole lot of guidelines around asthma and COPD, as you can imagine, and the ACSM guidelines would lead you nicely down a nice summary for that. But it's patient assessment. For me, referring to the right person is really important. Someone who understands the condition, understands the pharmacology, how it affects their exercise capacity, how it affects your ability to monitor their intensity, those kind of things. So if someone has asthma, for example, and they're regularly using an inhaler before they exercise, then monitoring their heart rate is probably completely pointless because it's going to elevate their heart rate, at least in the short term. So we have things like perceived exertion scales that we would use to give people a guideline of how to exercise and what to expect. And again, the Borg scale is something you may well be familiar with. It's certainly used in cardiac rehab and COPD rehabilitation. Something that you could just direct the patient to safely monitor their exercise capacity, which is, I use it a lot here for sure, because you quite often find that people coming not just on one drug either, there are multiple drugs, and that can do all sorts of things to heart rates and responses and orthostatic issues and all of those things that a patient, if they're not aware of, will be absolutely terrified of.
And I think also, you brought a paper along to one of the meetings that we've been in together about the effect of antihypertensives on your body's response in exercise. Tell us a bit more about that.
Yeah, well, that's a classic example, actually. We have lots of people who come through the door here on multiple pharmacology for high blood pressure, 2 or 3, maybe 4 different meds. And once they start bringing exercise into the mix and they get that post-exercise hypertensive effect, which is a massively marked effect, actually, which is why exercise is so effective for reduction of blood pressure over time. And they find that suddenly their medication is too aggressive and they start experiencing orthostatic responses and dizziness when they stand and things that terrify them, quite frankly. And if they're not aware of those potential interactions, it can put them off activity. And they'll say, well, I started exercising and suddenly I got dizzy. And that terrifies them. So we need to let them know about all these potential interactions.
Terrifies me too.
Rob, I think that's a really interesting point that I just wanted to pick up on, because I think we often have one opportunity with people. So they may come, they're kind of contemplating taking up physical activity and we need to get it right. Or if we don't get it right, it might put them off for a long time. And obviously competence is a big part of that. But when someone comes to you, they turn up at your door. What are the first things that you do in your practice just to make people feel comfortable and to kind of break down those barriers that people might or the kind of the cross that they might carry as they arrive at your door?
Well, as I said before, I have the luxury of having time. So I can sit them down and do an in-depth history about their experiences of activity, what they like, any diagnosis they have, what medication they're on, previous experiences about being in an environment like this, for example, exploring barriers around all the lifestyle medicine protocols, really, how they sleep. Do they have a social outlet? Do they like to exercise in a group? And, once we've unraveled all that stuff and we've knocked down some of those barriers, then we start looking at how their medication and their comorbidities and their orthopedic issues might interact with the decisions they're making about activity. If someone wants to run a marathon and they've got arthritic knees and they're on 3 or 4 different medications for different things, it's not going to be an appropriate starting point, at least. And you'd be surprised how many people have that perception that they're going to go from doing nothing to doing something really intense very quickly. And there's a huge bit between that top end and where they start. And part of my job is to advise them. And very commonly, what I do here is I meet people who are exercising at the wrong level and having problems. So we end up scaling them back a bit and giving them something more appropriate. That in itself builds confidence. And once they've got the confidence, you'd be amazed what they can achieve. They certainly are.
It's so often, doing the simple things well, isn't it, Rob? What I'm hearing from what you're saying there is start low, go slow. And if you're going too fast, then just cut it back a bit. And just being generally sensible, isn't it?
Yeah. Rob, going to put you on the spot. If you got very short, if like Suzy and I, you've got very short time with someone, what are the real tips that we can do in that time to kind of keep people motivated and possibly move them through that cycle of change?
Well, I guess we know that this is all about behaviour change. So I'm guessing the first question is, what have you done previously? What do you like? And then you can kind of integrate that with the information you have in front of you with regards to their clinical diagnosis potentially and what medication they're on. And then you can pick up your ACSM manual and look at what it's guiding you towards. Because believe me, this is a really comprehensive piece of literature. So if you have someone who's on multiple pharmacology for high blood pressure and has arthritic knees and wants to go and do some exercise because they know it's good for them, then for you, it's about what have you done previously? What are you looking to do in the future? And how, you might want to be aware of this, and this as you start. Can you get all that into a 7-minute consultation, guys? I guess is the question.
Oh, I'm a firm believer in seed planting as well. Even if it's not going to work on consultation number 1, hopefully if you've got a team around you that's going to bring up the same conversation again, how many times is it you need to be introduced to an idea or a new food before you'll accept it? I think we just need to be doing this constantly, low level, encouraging people to see what's possible. I think But what you say about word of mouth as well is really important, isn't it? It's folk like me. It's being inspired by other people who are doing what they're doing and learning from them.
Yeah.
We spoke a minute ago about things that strike fear into our hearts as GPs. And one of the other ones, Rob, I want your reassurance. What about patients with angina? What do you do with these patients who have a background cardiac condition?
Well, the utopia for anyone with a cardiac condition is proper assessment. And unfortunately, we don't often get that. So I'll have someone turning up here who has been diagnosed with angina and been put on medication to manage it and has been told to get fit. And they've kind of been left at that point. What I'll do is I'll assess them. I'll sit and have a conversation with them, reassure them that exercise is a really good idea, because it is. We've got lots of evidence for that. And then we'll bring them in and I'll have to do some kind of a field assessment of some description, which will be probably something as simple as getting to do a mode of activity that they're comfortable with and a talk test, or using a ball scale just to kind of see where they're at. I think the most important thing is reassurance and showing that they can be safe and teaching them how to monitor themselves safely. In any cardiac rehab program, that would be something that they would spend weeks doing, for example.
I'm probably going to take a bit of a sidestep here, but one of the things seeing a lot at the moment is people coming in asking about Wegovy and Mounjaro and the kind of the medication that are kind of being marketed as these wonder drugs. I actually, it presents a lot of challenges, no doubt, but I think it also presents an opportunity because people are suddenly aware or being made aware of the impact of obesity on health and the need to manage that. And so I kind of wanted to segue into metabolic health possibly, and how you manage people with metabolic health. And I think that the people or as the pathways for the prescription of Mounjaro, Wegovy are established, there's opportunity in there. And I think we need to be mindful of having these conversations. So yeah, just what do you do to encourage people with diabetes, metabolic syndrome to be more active?
Well, those prevalent conditions I see, certainly in the last couple of years, been exactly those things. Metabolic issues, sure. Metabolic syndrome, diagnosing people in the 30s and 40s who are clinically heavily overweight. And because I work alongside the private sector, I am seeing a lot of prescription of the drugs you just mentioned. So there's no question that exercise should be a cornerstone of diabetes therapy. Absolutely no question. We've got so much evidence for that. If we can tell people that if they can get a little bit more lean body mass, for example, they're going to dispose of this excess glucose in their system. We can tell them that being physically more active, even something as simple as going for a walk, if they're really sedentary, they're going to see quite significant changes quite quickly. We've got a lot of evidence for that. And if you link that to the prescription of things like Mounjaro and semaglutide and things like that, there's also the issue around preservation of lean body mass, because we've got quite a lot of evidence that those drugs not only obviously affect weight with regards to body fat, but they also attack lean body mass as well, muscle mass. And in my work with these patients, our ultimate goal while they're on this journey of semaglutide or whatever they're taking is to ensure that they come out of that process with preservation of lean body mass, and then the ability to dispose of glucose going forward.
How many people do you think are actually aware that their lean body mass is being affected by these medications? Do you think that message is out there?
I'm not sure it is. I think it's growing. If you look at, I'm not on social media personally, but I get given a lot of things by my clients that they've read, and I think the message is starting to change. Unfortunately as well, and you'll probably see some of this yourself, there are plenty of people who can afford to buy these drugs on the black market who don't necessarily need them that are taking them. And they are having real issues. I'm seeing that here. They're having real issues around loss of function and lean body mass in their 30s. They're taking drugs they don't need because they want to lose weight for a holiday, for example. I'm sure you've met people like this yourselves. They don't really have a metabolic issue that would warrant that prescription. And that's definitely a message we can give to those people. With regards to the metabolic patients, I guess that's something that you guys could be saying if you're coming across these prescriptions, the importance of maintaining good function, good lean body mass while they're on the journey. I think most prescription journeys are 12 to 18 months, aren't they? And that's if you're losing lean body mass over that time, By the time you end that process, you could have lost a significant amount of muscle and actually function as well.
I think it's a really interesting point, Rob, that we need to be doing these. I think there are appropriate prescriptions of these drugs and people that need them. And I'm definitely seeing people up here in Scotland who are buying it online because they want to lose weight and it's not available. But I think it needs to be done in conjunction with lifestyle changes, because otherwise it will end up in a kind of either a dependency or a yo-yo effect. And so, yeah, I think that's a really important point. And I suppose it interlinks with that lean muscle mass as well, or lean body mass.
Well, it's back to that behavioural aspect, isn't it? I mean, the reality is if people are being prescribed these drugs because they have a clinical need and they're not addressing how they got there in the first place, potentially when they're coming off the medication, they're going to end up in the same spot. I mean, there's a lot of evidence to say that the weight regain after coming off these medications is quite significant. And actually, some people that I've seen here, actually, or we're starting to see it, that they're not necessarily addressing the behavioural aspects of how they got what they got, and they are about to go back on the journey of eating the wrong foods, not necessarily addressing the lifestyle issues. And when the medication stops, they have two choices. They regain the weight or they stay on the meds. And I'm not sure there's a huge amount of evidence for long-term use of those medications. I'm not sure. You might better tell me that.
Definitely a political hot potato. And in my diabetes role, we were just talking about this yesterday. And, the emerging problems with the combination of obesity and malnutrition, I think is one that worries me. But I guess that takes us slightly off the discussion about physical activity. But definitely more to come, I think, on that topic. And it will be interesting to see how that evolves. But really important that we know about this, because I don't think that knowledge is widespread about the loss of lean muscle mass with a lot of these medications.
And it's certainly something that we are very focused on. If we're confronted with someone who's on this drug regimen, then we are very much focused on that. And they seem to buy into that quite well, actually. I mean, most of the people are quite interested to know, as you rightly point out, then they weren't necessarily told that. Although, because I work in the private sector, the guys I work alongside are lifestyle medics, so they're able to give that information when they're prescribing, which obviously you guys may or may not be able to do.
Can you clear something up for me? I have read various things. I'm not an expert in managing the metabolic syndrome or obesity, but, people say, well, actually, physical activity is not going to get you slimmer. You're probably going to gain weight if you do exercise because it affects how hungry you are. What would you say to that?
Well, there's absolutely no question that when we've got lots of evidence to suggest that people, if you're using exercise purely for weight loss, then obviously I think you're barking up the wrong tree. We've got lots of evidence to say it has lots and lots of benefits with regards to how you manage your metabolic health, how you process glucose. But from a weight loss intervention, as a sole weight loss intervention, there's not a huge amount of evidence that exercise on its own, at least, will have a massive impact. In conjunction with dietary changes and other things, then we get some really good outcomes. But the message I always say to my clients is, ultimately, exercise is going to do lots of things for you. It's going to help you manage your blood glucose much better, etc., etc. But if you're doing this purely to lose weight, then we probably have to have another conversation around nutrition as well.
I think the other point there is there's pretty good evidence to show that it's helpful for maintaining weight loss once you have lost it. And so it's a fairly integral part of the approach to sustain weight loss.
Absolutely. And I wouldn't argue with that. And again, it goes back to that conversation about if you can get everyone engaged in this process, then they all of these things have their role. Physical activity has so many benefits. But when people get on the scales and they don't necessarily see a weight loss because their lean body mass is going up, again, an education and a conversation around that is really important.
I think my narrative on this has changed dramatically over the years. And I now actually tell people, do you know what? Just move the scales. I don't know why we do a BMI. What you need is the trousers of truth in your life. So we all have a pair of those trousers that will let us know where we are on our journey and how we feel and how, because all of the pillars of health are interrelated. If I haven't had my physical activity for the day, I'm not going to sleep particularly well. And then I'm going to be stressed and grumpy. And then my relationships might suffer as a result. And then I'll probably drink too much coffee. I'm thinking about sort of substances, and that was the one that sprung to mind, and things that are harmful for us. So, it is, there's so much here, Rob. I could talk to you all day, and we could learn so much more from you. But I think you've given us some real pearls of wisdom today. And I'm going to do a little bit of a take-home message thing. And I'm going to go first, and then I'm going to come to Callum, and then Rob, you're going to give us your take-home nuggets for people in primary care to because this is what we're about in the Movement Prescription podcast. It's about trying to encourage our colleagues to do this better because we know that it works. So take-home message for me is that I'm going to have to get revise the Borg scale, because I think that sounds like a really important thing just to be able to refer to. And I'm going to get myself another book. I am a bibliophile. I have more books than I can ever read, but it sounds like a really important reference to have actually on hand. So those are my 2 take-home messages for today. How about you, Callum?
The Faculty of Sport and Exercise Medicine statement on risk, which says there are some, but there's almost no circumstances in which the risks outweigh the benefits is really important. And so kind of possibly reframing the whole worry about liability and saying, well, are you causing harm by not promoting physical activity to your patients?
Oh, and my one, from the perspective of the pearls of wisdom you mentioned, I guess the question is, guys, we know that exercise is a cornerstone of everything from regards to therapy for clinical conditions. And I have had so many case studies here that kind of proves that. From your perspective, your message in your surgery in that time frame you have is going to be that, in many cases, the difference between someone adhering to something or at least starting it. That physician message endorsing something is everything. So tell them it's important, maybe warn them about some certain bits and pieces to be aware of, or at least advise them. And then if you get the opportunity, follow them up.
Brilliant, Rob. Thank you. It's been an absolute pleasure to have you here. I will be doing brief interventions, giving people the confidence that you talk about there. Thank you so much, and take care of yourself.
Thanks, Rob.
Okay, great to see you guys. See you soon. Take care. Bye-bye.
Hi, it's Callum. I really hope you enjoyed the episode. We are so grateful to the British Society of Lifestyle Medicine for their support in producing these podcasts. And we wholeheartedly share their vision of transforming healthcare and levelling health inequalities through lifestyle medicine. If you want to find out more, please head to bslm.org.uk. Although catering for healthcare professionals, this podcast is for everyone. If you enjoyed it, please share it. And we love hearing from you, so do reach out. Thanks for listening.